Hello, I'm ready to teach. I hope you're ready to learn. And today we're going to talk about eye conditions. And these are ones that are constantly being missed when students are in my office, partially because they get the symptoms of them confused. So if you're on my email listing, this is going to sound like a repeat, but it's a good repeat. And if you want to be on my email listing, then my email is attached to the YouTube channel. You can get it there, or you can contact me through YouTube. Either way, okay? So eye conditions. Now, the ones I'm talking about are the four biggies, the ones that are constantly coming up. So this is the graph that I sent out recently in my email informational that I send out on Saturdays. It has broke down the symptoms for cataracts, for glaucoma, for retinal detachment and macular degeneration. In my office, it's constantly cataracts, they say, that has pain, or they get the peripheral and central vision ones confused. So hopefully between seeing this and then us going through them individually, it will become clearer to you as to which one is which. So the first one we're going to talk about is cataracts. Cataracts happen because of age. They're an old age problem. The client loses the opacity of the lens, and that distorts the image that's projected on the retina. This can lead to blindness if it's not treated. The causes of cataracts include the aging process, hereditary, injury, or any other eye disease. And this picture here is a good example of a cataract. That person probably can't see hardly anything. The symptoms of cataracts: blurred vision, they have a decreased color perception, they can see double or diplopia, they have a reduced visual acuity, they have an absence of the red reflex, and they have the presence of white pupil in the late stage. Their loss of vision here is gradual. The surgical intervention is needed to remove the lens one eye at a time. So preoperative, we're going to instruct the client on hand washing, prevention of increased intraocular pressures such as bending over, coughing, straining, and rubbing the eye. And you have to remember these things even after surgery to help the patient not do these things or help prevent them from doing them. Teach the client after surgery that installation of eye drops several times a day for 2 to 4 weeks is required, and they have to know how to do that preoperatively. They're going to be giving drops preoperatively. Then post-op, we're going to elevate the head of the bed 30 to 45 degrees. That is one of those prevention of increased intraocular pressure. Going to have the client on their back or their unaffected side. You're going to orient them to the environment. You're going to put their belongings on the unaffected side and have the client use side rails for safety and assist the client with ambulation. And of course, we're going to also help with putting in the eye drops. They will be wearing a patch. They wear a patch at night, and that's on the affected side. Okay, glaucoma. This is a group of conditions that increase the intraocular pressure. Now remember, with cataracts, we still wanted to prevent that. But this one, the issue is the intraocular pressure is increased all the time. And it has to do with the fluid or the aqueous humor in the eye and the pressure of that within the eye. The normal range is 10 to 21, and an increase is due to the inadequate drainage of the fluid, the aqueous humor, or there's too much of it. This increase in pressure damages the optic nerve, and that's the whole problem with glaucoma. So signs and symptoms, they're going to have diminished accommodation. So when an object is close or far away, that accommodation is not going to happen as easily. They're going to have increased ocular pressure. It's going to be painless and vision changes that are slow that results in tunnel vision, and that's the primary open angle. The blurred vision, halos around the lights, and the ocular erythema is the other one. So treatment for acute angle closure glaucoma is a medical emergency. The medications are prescribed to for that intraocular pressure. We're going to prepare the client for peripheral iridectomy, which allows the aqueous humor to flow from the posterior to the anterior. Remember, when you're dealing with glaucoma, it has to do with that flow and whether there's too much or not enough. You got to remember that when it comes to meds too. Anticholinergic med is not something you want to give these people. Treatment for glaucoma client themselves are the meds and their importance, instructions on the fact that it's lifelong, that they're going to use those meds, and the need to report eye pain, halos, visual field loss, changes to the vision to the MD. All right, so retinal detachment. This one's a little bit more intricate as to what's going on. The retina, let's find it in the picture here. The retina is here, it's the yellow, okay? When it detaches from the epithelium, the outermost layer of the cornea, which would be this here, when it detaches, and then there's fluid accumulation built up between the two surfaces. Both the retinal layers elevate away from the cornea as a result, and partial detachment becomes complete if it's not treated. And that's when real blindness occurs. So this is a very good picture of the eye. I like this. That's the reason I used it. So symptoms for retinal detachment, they're going to have flashes of light. They'll have floaters or black spots. They'll have a sense of a curtain being drawn over the eye. A loss of portion of the visual field. It's a painless loss of central vision and peripheral vision. Preop care. They're going to be on bed rest. You're going to cover both eyes with patches as ordered. You're going to speak to the client prior to approaching so they know you're coming. You're going to position the client with the head as prescribed. You're going to protect the client from injury. You're going to encourage them not to jerk their head, so avoid jerking head, minimize eye stress, and prepare for the surgery. So draining the fluid from the subretinal space so that the retina can return to normal position, or sealing the retinal breaks with use of cryosurgery, or the diathermia, where it's the use of an electrode and heat through the sclera to stimulate the inflammatory response. These are all things that they can do to help repair this. So post-operatively, we're going to maintain the eye patches as ordered. We're going to monitor for hemorrhage. We're going to prevent nausea and vomiting. We're going to monitor for sharp, sudden eye pain and notify the doctor immediately that eye pain is very important. Encourage coughing and deep breathing, bed rest as ordered, position the client as ordered, and of course, those all important eye medications. So more post-op, we would assist with their ADLs. We would help ensure the avoidance of sudden head movements. We'd have the client limit their reading for 3 to 5 weeks after they go home. They need to avoid squinting, straining, or constipation, lifting of heavy objects, or bending at the waist. Remember, this is all going back to that intraocular pressure and preventing it from increasing. So it's important to pay attention to this all the way through these. They need to wear dark glasses during the day and an eye patch at night, and then follow up due to possible reoccurrence. Then macular degeneration. This is the last of the 4. It's a deterioration of the macula. It's the area of central vision. It can be age-related or dry, called atrophic, or exudative, which is wet. The age-related is a gradual blocking of the retinal capillaries, and it advances to ischemic or necrotic macula. The rod or the photoreceptors die. The exudative is a serous detachment of the pigment epithelium to the macula, and scar formation occurs due to the fluid and the blood collecting under the macula. The interventions for this is maximizing the remaining vision. The picture you're seeing is what a patient with macular degeneration would see. So the signs and symptoms are a decline in central vision, blurred vision, and distortion. And if you look at this picture, you can see just how the central vision is really not there, and what is there is very blurred. Interventions, you're going to initiate strategies to assist them in maximizing what vision they have left and their independence, whatever that takes. So that would include the environment they're in, setting it up, maintaining it the way they know where things are at. Referrals to community organizations. They do use laser therapy, photodynamic therapy, and other therapies can be ordered. So these are the 4 big eye conditions that I can say here in the office are ones that people get confused. I hope that I've helped you separate them out, and I hope this has helped you. So I will see you next time. Have a good one until we see each other again. Bye-bye.